Thank you so much. Thanks for coming out this morning. So my topic today is one that's near and dear to my heart because as surgeons in transplantation, we don't always get the first crack at immunosuppression. And when I first came back to Western, it looked like all the nephrologists controlled all of the immunotherapy trials. But one thing that they couldn't really control is what happens when the kidney comes out of the donor and into the recipient, and actually a lot of them have no clue what happens in that realm. So the first thing I'd like to do is kind of introduce make you aware of the actual problem that we have in transplantation, and you'll see in urology. So this is ischemia reperfusion injury. The first part is ischemia. That's a lack of blood flow and oxygenation to tissues or organs, and the lack of ATP will result in either reversible, and sometimes it's quite damaging, irreversible cell death. Then comes the reestablishment of oxygen and flow, which is the reperfusion injury. And first of all, what happens is you have altered endothelium. Everything becomes sticky, the neutrophils amplify, adheres, and migrate into the endothelium and create a system where there's a reactive oxygen species, and there's a cycle of changes. Now this is a little video with one of our collaborators, Andreas Linkerman. And what he's done, this is an intravital microscopy looking at a mouse clamp model with 30 minutes of renal pedicle clamping. And this really just shows the immediate 2 minutes, 60 minutes of what happens in a rapid time after unclamping. And what you'll see is in the red is propydian iodide, and that's basically necroptosis. It's regulated necrosis, and basically you'll see that some of the tubular epithelial cells in the green spewing out some of the red ink, which is the DAMPs, the damage associated molecular patterns, which cause further inflammation. What you'll see in this video with the arrow is something that's a PI positive nucleus, and if you look in the area, you can see that particular cell exploding, and the damps appear into the lumen. So this is something that you can actually see on a real time with some of our clamp models. So you can see how it's applicable to something like transplantation or partial nephrectomy procedure. So I'm very interested in the renal procedure. So this is the area that I've been kind of studying over time. In transplantation, there are many steps to creating injury, and that all starts with the removal of the organ during procurement. And you have a warm injury at first, and then there's further damage with cold injury, because even placing the organs in cold that does cause injury to the cells, and then the reperfusion injury. And all this is before you talk about the toxicities of the immunosuppression and the chronic rejection that follow. When Chris was with us in London, we looked at a nomogram, looking at different factors that may affect graft survival. And of course, so one of the factors up here is called ischemic time, and it's always been a battle to get these organs in quickly, and therefore one of the strategies is to limit ischemia, get the organ in as quick as possible, and you have that with living donor operations. Or some other strategies are really to alter the inflammatory or death pathways and really change the vascular dysregulation that happens with the reperfusion injury. Sometimes the body will show you the way. So within our bodies, we have small endogenous molecules. Hydrogen sulfide is one of them. The one I've been studying for a while, for over about 10 years, is carbon monoxide. And when you have heme, it's cleaved into carbon monoxide, bilirubin, and iron. And what happens is with this little molecule that seems so many people attribute to be toxic, is that through different pathways, it can be vasoprotective, vasoregulatory, and through the same pathways, including NF-kappa B and MAP kinase, can reduce inflammation and reduce cell death. And you see these things pop up in the slides over and over again: vasoprotection, reduction of inflammation, and reduction of death. And we'll see this. Well, what we normally attribute carbon monoxide with is the carboxyhemoglobin. So basically, carbon monoxide will bind to hemoglobin, preventing proper oxygen delivery, And at 35 parts per million, people will have headaches with constant exposure. At 1,600 parts per million, people can be insensate after 2 hours. You double that, death within 30 minutes. And at 16,000 parts per million, death within 3 minutes. But fortunately, we have different molecules. At first, it was heavy metal cores. Now we actually have one that's bound to manganese, some elemental molecules that release carbon monoxide over different half-lives. And with our last iteration with Corm-4, the release is over about an hour or two. And in physiologic conditions where it's beneficial, there's very little carboxyhemoglobin formation. And with regulation of endothelium. First of all, inflammation. In some of the basic work that we've done, we've shown that in the middle, carbon monoxide releasing molecules reduce some of the expression of adhesion molecules like ICAM or E-selectin. This results in reduced endothelial to neutrophil interaction, and Corm is here right compared to all controls. And then therefore reduce reactive oxygen species. So here's a reactive oxygen species hallucinogen assay showing again that carbon monoxide really reduces all these things within the endothelial cells. What we've done is we've done some experiments where we actually will inject the donor mice in an isogeneic, so it's the same strain mouse transplants with carbon monoxide releasing molecules, and then store the kidney for 24 hours and then retransplant them. So that's a kind of a long time for the mice. And when we inject them just intraperitoneal with carbon monoxide releasing molecules, that we get the indefinite survival where this type of this model will lead to death invariably in all other with other injections and controls. Here's cell death, necrosis. So when we store these organs under the cold actually causes damage. Here you have on the y-axis 7 AAD, that's necrosis. The next in 5, that's apoptosis. And here's we have 37-degree control. So at at physiologic body temperatures, these cells, these tubular epithelial cells are quite happy. When we freeze them at 4 degrees control, which you get down to when you put the organs under and cells under cold temperatures, you see a migration over to the right side where there's a lot of cell death. Put carbon monoxide releasing molecule, but all the cells kind of sit in this happy left lower quadrant zone where there's no death or with related to apoptosis or necrosis. And it's usually through some mitochondrial pathways like BCL2. All right, some preclinical models. So we use contemporary pumps, and the nice thing about pig kidneys is that they're not expensive to use, and the kidneys are large enough that we can actually use our current pulsatile perfusion machines. And when you give carbon monoxide releasing molecules or a sister molecule, the hydrogen sulfide, you can see the mean vascular resistance within the organs are reduced. So that's one of the other components. So there's inflammation, cell death, and vascular regulation. There's better vascular regulation, and this also translates into better kidney function. These pigs underwent isogeneic transplants. So what we do is we, without any type of it's a regular nephrectomy. They undergo nephrectomy. We leave the left kidney in the pig, remove the right kidney, store it for 24 hours, then transplant it back onto the aorta and cava, and then subsequently remove the other organ. And so by post-op day 7, the creatinine is running about 350. If you give hydrogen sulfide, one of the other small endogenous molecules, then basically the creatinine kind of tapers off at 170 by post-op day 7. Same thing with carbon monoxide releasing molecules. Both of them kind of work in very similar ways, but through different mechanisms. But when we give the combination of the two, it's almost like by day 7, the creatinine is sitting at about 100. So it's almost as if the organ has been untouched. So those are kind of little strategies that we've used in preclinical models. Clinically, we haven't used the carbon monoxide releasing molecules and as such, but we're working towards that. What we have done is used calcium channel blockers, and Dr. Guan helped us with some of the early work in this, where we looked at verapamil, which actually works at the mitochondrial level. It establishes, just like carbon monoxide, vasoprotection, reduction of inflammation, reduction of cell death. What we showed is that over about 6 to 12 months, the renal function of the matched kidneys that we were, and we basically infused verapamil in the perfusate into the second kidney. So you think the second kidney, the patient receiving the second kidney, would be at higher risk. Their GFRs were superior to the ones that had the standard HTK solutions. So what's the state of the art? Here's a we use. Do you guys use pulsatile perfusion or just straight HTK for storage?
No, we do.
Use that too, yeah. This is a systematic review done by one of our residents, Varun Bathini, looking at the use of the pump for DCD kidneys, and invariably, most studies do show that it's superior in reducing delayed graft function. So when we actually added the verapamil compared to the matched kidney in a randomized fashion to the perfusate, the pump perfusate, we had earlier better allograft function, as indicated by creatinine clearance, and that even by 1 year we have a better renal function with the verapamil infused kidneys compared to control. And that's like a $5 bottle, 5 milligrams of verapamil that we've been using. So what about IRI outside of transplantation? Most of you here don't do transplants, but do general urology. How does it apply to urologists? And the way I look at it really is, again, with what's translatable is with partial nephrectomy and radical nephrectomy. So really, this poor renal function affects the survival of our patients. And so this is one of the papers that you see a lot with people who deal with partial nephrectomy and radical nephrectomy. Is a paper by Go looking at the patients with GFRs less than 60 or greater than 60. And the ones that have an inferior GFR have a 20% increased risk of death, and a lot of that's because of cardiovascular morbidity. So yes, your kidney function will affect how long you do live. And about a quarter of our patients that are undergoing radical nephrectomy for RCC have GFRs that are low. So in transplantation, we always use this magic number, 80 mils per minute for 1.73 meters squared. And that's for our donor kidneys. A lot of us don't will say that a patient would be excluded if they have a GFR under 80 for donation. And you think that it's to protect the donor, but actually it's to protect the recipient at first, because they thought that if we gave one of the two kidneys to a recipient undergoing immunosuppression, it would be inadequate for the long-term survival of that individual. But really, the donors, it turned out that if we use 80 mils per minute, to a good extent, we're not harming the donors as well. So that number has stood the test of time. So this number applied to the patients undergoing radical nephrectomy as well. But these patients are older, heavier, they smoke, some are diabetic and hypertensive, unlike our living donors who are completely healthy. Here's some work done by one of the oncology fellows in London a number of years ago, looking at patients undergoing radical nephrectomy with GFRs above 60, but stratified between 60, 80, or 80 and above. And these are patients that are at risk of developing stage 4 renal impairment, which some people say would ultimately lead to renal replacement therapy over time. And you can see that the ones that have a higher GFR perform better in staying off stage 4 renal impairment. And by about 5 years already, 7% of the GFRs between 60 and 80 required renal replacement therapy, where none over 80 required dialysis or transplantation. What does that mean for survival? Well, here's a study looking at patients with GFRs less than 45 to 60, and greater than 60, looking at overall survival after radical nephrectomy, and independent of the tumor stage and grade. The patients with higher GFRs perform better with regards to survival. So what can we do about that? So we can do partial nephrectomies, and this is not surprising. And many individuals have shown, and it makes sense that people who have partial nephrectomies, long-term 5 years follow-up, have reduced delta GFRs compared to radical nephrectomy. So a loss of 37 mils per minute versus 11. And then came up this publication a number of years ago looking at randomized prospective ERTC intergroup phase 3 study looking at radical and partial nephrectomy, and it's, a lot of you in the audience have gone through this, may have contributed patients to this. It kind of shocked everybody, because really the patients undergoing radical nephrectomy did just as well or better in terms of survival. And I think there's a lot of, it's the only randomized study that had been published about this at the time. And what was kind of scary about this is everyone was at the time was proposing that partial nephrectomy was better, but I think the way that the study came out, because of its timing when it was done, and the ability to accrue the right patients, and probably there may be a accrual bias, so that that patients who had higher comorbidities, diabetes, hypertension, maybe poor GFRs, were excluded from this randomized trial, and therefore you're almost looking at a group of individuals who underwent radical nephrectomies that kind of appear a little bit more like the donors, the living donors, who are a little healthier, and maybe that's the reason why there's a question about it. But nevertheless, I think a lot of us have moved on and still have to decide if patients in a certain demographic should undergo radical or partial nephrectomy. For example, a 65-year-old individual with a left 6 centimeter mesophatic renal mass, GFR is about 75, has some diabetes, hypertension. What's the best thing to do with an individual like this? Do we go with a partial or radical nephrectomy? And with a radical nephrectomy, of course, it's an easy operation. With a partial, it may be a little more challenging and subject to more complications. When we looked at our database in London with different factors that may affect GFR post-radical nephrectomy, diabetes came out as a big factor that may help. And knowing that, as we know, the preoperative GFR would help determine whether or not someone falls into a greater stage of renal dysfunction post-operatively. So we take this individual, do a radical nephrectomy, and they have a history of diabetes, then you can almost predict that they may have they fall into CKD level 4 post-operatively. But if you do a partial nephrectomy with diabetes in our patient groups, then you may end up with lesser disease, and someone sitting at CKD level 3 and go on to stay off dialysis for a number of years. So there could be some decisions that made according to the comorbidities of these patients. We also will present some work showing that the resected renal parenchyma and tumor size are associated with decreased renal loss after partial nephrectomy as well. So, but these are unmodifiable risk factors: the age of the patient, whether they have diabetes or not, preoperative GFR, where's the tumor, size, location, and depth. Other people have published the same type of information about the tumor location and size. But the things that we can change are things like how long do you clamp these kidneys? Can you give any drugs? Should you cool these patients? Can you precondition them in any way? So one of the first tenets of when you do partial nephrectomies, of course, is clamp time. We want shorter clamp times. Therefore, you have reversible damage rather than irreversible damage, and you may be able to circumvent that necroptosis that we saw in that video. And there's evidence that time matters, how long you clamp, but I think there's a little bit of debate: how long can you clamp these kidneys for without much damage? And Perec in Miami says 30 to 60 minutes. There's not a morphologic change on follow-up CT scans. If you clamp the partial nephrectomy the patients with partial nephrectomies for that period of time. Some people say anything under 40 minutes is okay, but really with some of the partial nephrectomy experts that are really trying to push the envelope, they've made us do selective clamping and there's some individuals that they do these kidneys completely off clamp, but sometimes when you can't see the renal bed and everything's bleeding, it makes the operation harder. You may have more positive margins. So what we've tried to do, we've looked at, and even though this technique has been used, and I know that some individuals in this institution use it, but we've shown that if we take the clamp off one step earlier than we used to, thereby when we do a whip stitch, when we do laparoscopic partial nephrectomies, and then take the clamps off at that point, we reduce our times from the standard approach of closing the entire the bed from 30 minutes to about 18 minutes through laparoscopy. It hasn't really changed the way that we the complications that we have or the blood loss that's associated with the partial nephrectomy procedure. And Jeff Campbell from our site looked at this, and using nuclear reninography preoperatively and postoperatively, about 6 weeks postoperatively, it's shown that that with the early clamp release, there was a beneficial reduction in the loss of GFR with the early clamp release. So even changing things from 30 minutes to 18 minutes seemed to have helped that renal unit. And it may not be important in someone who has excellent kidney function bilaterally, but with someone who has compromised kidney function, that may be quite important. Also, the ones with compromised renal function may have less of a capacity to recover from the clamp as well. Some of our colleagues at Western have looked at off-clamp and ALP centers. Someone who works with me in transplantation, but he's been trying to use the Ultras or some other device, hemostatic devices, to do off-clamp partials. Most of the ones that he's done here have altered renal function, a couple solitary kidneys smattered in there, and really after doing these off-clamp partials, the renal function isn't really changed from the pre-op to the post-op. Here you can see 49 to 46% with the split differential function on the side that had been clamped. What about arterial clamps? So do you clamp the artery in the vein or just the artery alone? And the rationale about clamping the artery alone is that the venous back perfusion is beneficial to the parenchymal preservation. And the evidence is that, with pig models and early on, with some studies that were done in Chicago, that if you clamp the artery only laparoscopically, it had superior results. Other groups have shown actually no difference if you clamp the entire hilum or the artery alone. So really, it depends on what your preference is for these partial nephrectomies with regard to the bleeding. What about cold ischemia? So the rationale, of course, is you reduce ATP during the ischemia. You put these cells into hibernation. But as we said, that if you cool these kidneys, it causes damage as well. So the evidence here is really debatable whether a warm ischemic time of 20 minutes or if you pack it with ice for 15 minutes before chopping out the lesion, if there's really any much difference. And of course, we're still waiting for that the Canada-wide randomized controlled trial looking at open partial nephrectomy, whether cooling or really does affect renal function post partial nephrectomy at all. And here's ischemic preconditioning, and really the rationale here on the left side is all the animal studies that have been looking at ischemic preconditioning, and it seems like it's going to be a very positive type of procedure where you put a blood pressure cuff or a clamp on the leg or of the animal, and then an hour before or 18 hours before, and everyone's done something a little different, and then cause ischemia to an organ to see if there's any changes. And it's overwhelmingly positive. Clinically, it really does favorable. It's favorable for some cardiac studies, liver studies, and lung studies. But the one that they've looked at for partial nephrectomies, although they did show that early function was a little bit better if you placed the blood pressure cuff on someone's leg, created ischemia for 5 to 10 minutes. But really, there's no long-term effect. There's no long-term benefit from doing it for partial nephrectomy. Mannitol. So people who are writing their exams know the tenets of mannitol, right? Free radical scavenger, reduces cellular swelling, diuretic, vasodilator, prevents cast formation. This is in Campbell's Urology, and but a lot of it's just based with some rabbit clamp studies back in 1979, and in partial nephrectomy, Nick Power, who's at our center right now, when he was with John Coleman, looked at all the partials that were done with and without mannitol. It really found that the mannitol didn't change all that much. When you look at the patients undergoing partial nephrectomy with different preoperative GFRs. What about other drugs? So we have things like steroids, immunotherapy, and clinically, that hasn't been really tested. Erythropoietin, although a lot of people have looked at that, basic science, there has been really no improvement in administering erythropoietin during partial nephrectomy. N-acetylcysteine that we use with contrast-associated nephropathy, not tested for partial nephrectomy. Statins, not tested. And dopamine, renal dose dopamine. And there's really no improvement in renal dose dopamine in improving kidney functions post partial nephrectomy.
Patrick, what's the rationale for, what's the rationale for EPO? I understand the NAC.
Yeah, it had some anti-inflammatory, like it was very like in small animal models, a lot of anti-inflammatory properties of using EPO, independent of what it does for the production of red blood cells. It's the same thing. I think statins has a big role. I think you guys use it in cancer and right and yeah. Yeah, but it actually is supposed to be very beneficial role in inflammation as well. So and we'll talk a little bit about reprocessing some of these drugs that are used for different reasons in IRI. So the approach, again, vascular regulation, prevention cell death, reduction of inflammation, using things like carbon monoxide releasing molecules. But at Western, there's a lot of other strategies. When Chris was there, they were looking at inhibition of IDO, interleukin inhibition, silencing of death pathways, and complements, and actually necrostatin is one that one of my colleagues is looking at right now. And what he's trying to do is he's trying to stop the pathway to necrosis, so it's pushing the death pathways towards a less inflammatory apoptotic one. So there's less of the damps that are released in that. So a lot of different work in ameliorating the IRI. So as Martin said, there's a lot of drugs that are out there for different reasons. Metformin, chloroquine, rapamycin, polymyxin B. These are drugs that are out there, and sometimes you can reposition a drug. And I think the CIHR are interested in these type of things because they can go into the clinic a little bit earlier and faster than something that's like carbon monoxide that's been developed by releasing molecules that are developed by chemists. And so, in summary, that from what I've shown you already, good renal function is essential for health, whether that's for transplantation or post nephrectomy. IRI can cause permanent damage to the kidneys, and our procedures are associated with renal IRI. And then agents and strategies that are capable of reducing IRI are important, but all these have to be tested rigorously. And really, there's a lot of people who are associated with this, including the fellows, the residents that have worked on this, the staff, and the people in the laboratory.